When are bispecific antibody and CAR T cell therapy used for DLBCL? And how might that change in the future?
At the present time today, both bispecific, glofitamab and ecoritamab, have the same indication, which is diffuse large B-cell lymphoma having received two lines of therapy. The first line of therapy is a classical immunochemotherapy, R-CHOP or R-CHP polatuzumab, and the second line depends whether a patient had received CAR T-cell, have received eventually transplant, or have received other kind of second line therapy. This is the current approval by FDA. But we are working very actively to bring this very active drug earlier in the management of the patient. And we have already clinical trials that are bringing this bispecific antibody in the first line setting, which means in combination with R-CHOP or R-CHP pola. These trials are being performed currently. We don't have the result, but it's not unlikely that in 2-3 years, bispecific antibodies for certain patients will be part of their first-line management. At the same time, we have also some studies that are being done in patients that are not candidate for CAR T or before CAR Ts that are envisioned because of the efficacy of these drugs. There is also a study that has been performed combining bispecific antibody with chemotherapy, showing a remarkable efficacy of this combination.
What does the future direction of research for DLBCL look like?
In diffuse large B-cell lymphoma, the goal is to cure patients. And cure is better achieved in the first-line setting, just after the diagnosis with the first treatment. There are different ways of thinking about that. The first one is to combine bispecific with classical immunochemotherapy, which is a treatment received by the vast majority of patients. We also think that some patients, particularly patients that are very frail with comorbidities or very older patients, may not be good candidates for immunochemotherapy. And we just opened a trial by my colleague, Dr. Toka, which administered bispecific with another drug, an antibody drug conjugate, initially in the management of the disease, in the intent to eventually diminish the immunochemotherapy, decrease the intensity and duration, and possibly in the future not having to do it. And I think this is a great hope for patients who right now are not good candidates for immunochemotherapy because of their stages. This is just starting, but other efforts are being done in this area. So that's bringing the first research, first-line setting. The second research that we are participating in and actively involved are combination with other agents. This can be, as I mentioned, antibody drug conjugate, but other immune-stimulating agent. We do know that bispecific engage T cells and activate T cells. Unfortunately, sometimes T cells are not fit or become exhausted. So we are using additional immunological signals to prevent this exhaustion or to increase the fitness of these T cells. Another research that we are doing in some of our trials is investigating the tumor before the bispecific and during the bispecific treatment to precisely understand the mechanism of action of this bispecific. What are the interplays between these T cells, the tumor cells, and the other cells that are in the milieu, in order to find ways to further increase the efficacy of bispecific. But again, 3 decades ago, the monoclonal antibody, anti-CD20, rituximab, and others have represented a major progress in the treatment of DLBCL. In the last decades, we have seen CAR T-cell being another tool. And here we are seeing a third tool which probably will generate major advances and will find its space in the armamentarium that we have. The goal again is to cure more patients, mostly in the first line. If this doesn't work in the first line, offering them a chance for cure later on in the disease.